Hi, this is Junaid back with Acute Ischemic Stroke 2019 Guideline Review. This is the last of the lectures of the IVtPA, and we'll discuss a few ending remarks as far as TPA is concerned. So, when we're looking at the bleeding risk, we have to consider some more options, and therefore it is important to reiterate that we have potentially said before is number one, the chances of having in the general population a low antiplatelet and coagulopathy is very low. So you do not need to wait for platelet count and coagulation studies before you initiate TPA. And if you do find it out, then you stop TPA. However, there's no reason to not initiate TPA in general population because the risk of having coagulopathy and low platelet count is relatively low. Patients with cerebral microbleeds between 1 to 10 or even higher, in those situations, the benefit is actually to go ahead and give TPA, and both of these recommendations are 2A, that is the moderate recommendations. But those patients who have known CMB, cerebral microbleeds, more than 10 with a known prior MRI, you should still consider it. However, the recommendation still remains weaker at 2B. You should not be administering glycoprotein 2B, 3A inhibitors with IVtPA. There's no recommendations for it, and therefore you should not do that as far as that is concerned. Similarly, if you're going to give a pixiximab, it actually produces more harm. There was a big study out of Houston Baylor that actually studied that, and we found out that we're causing more harm than good. So please don't do that. IV aspirin specifically should not be administered within 90 minutes of the IVtPA. Please do not do that. As a matter of fact, oral aspirin needs also be started after looking at the CAT scan that is done post 24-hour TPA to make sure there's no bleed, and then consider giving aspirin as well. And patients who are on low molecular weight heparin or full therapeutic dose within the last 24 hours do not give TPA because the bleeding risk is higher. So those are things that are reiterated in the guidelines, as we know and we discussed before. It is important that you maintain systolic blood pressure less than 180 within the first 24 hours after the TPA. And as far as antiplatelet therapy and antithrombotic therapy like aspirin and Plavix is concerned, should not be given, in my opinion, within the first 24 hours. The minute you hit the first 24-hour mark, get the CAT scan, then you can order those aspirin and Plavix to be given within 48 hours. It should be given as soon as possible, but it should not be given within 24 hours, especially IV aspirin that we have studied. We have not truly studied PO, aspirin and Plavix, etc. But the general recommendation is look at the CAT scan at the 24-hour mark and then decide which kind of antithrombotics you need to start the patient on. Now we come to teneplectase. Teneplectase, you can choose teneplectase as equivalently as far as eligibility criteria is concerned, is equally applies to the IVtPA. And then you can definitely use that if you want to use that. And teneplectase, the class of recommendation is 2B. Again, the reason that the class of recommendation is low is the level of evidence is low. If we do, as more and more studies comes out, more and more RCTs come out, the class of recommendation is going to go up as well. So in this situation, if you want to use teneplectase, go ahead and use as you would use IVtPA, and it is non-inferior. It is not superior, it is non-inferior. So it's basically equivalent to IVtPA. Other agents like sonothrombolysis and other defibrillating agents have not proven benefit. Do not use them. Thank you so much for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.